For many years, we have been really focused on congenital heart defects. And that's something that changed about 10 years ago in Uganda, where we worked with Dr. Craig Sable from National Children's, and he brought to us the concept of doing screening missions in the northern part of Uganda, in Gulu. And we did screening, and through Rotary, through the amazing network of Rotary up there, we screened 105,000 children, and we're able to begin getting a database as to the prevalence of rheumatic heart disease in Uganda, but also being able to transfer and translate that into other countries. And Owen mentioned he's working now in Zambia, and there's need all over the world to address this. I think one of the preeminent people that does this work is the gentleman who's going to be your luncheon speaker. I've asked him, he had a really nice presentation set. I've asked him to abbreviate it a little bit so it fits within our lunch period, but it will not take away of the importance of this work. This is perhaps the greatest growth area for gift of life in the world. Right now, we are helping 1,000 Ugandan children every year get penicillin that they would not be able to have otherwise, and they were identified through this collaboration. So our luncheon speaker is Pranava Sinha. He is the chief of pediatric cardiothoracic surgery and the co-director of the Pediatric Heart Center, the University of Minnesota Masonic Children's Hospital. It really is a great pleasure to have him joining us today. Dr. Sinha.
Thanks, Rob. It's a great honor to be here. I'm going to start with a little disclaimer, and if some of you are just wondering what a congenital heart surgeon is doing here, talking about rheumatic heart disease. And I have had the opportunity to actually train in 3 continents. So I started in India, and I learned how to do heart surgery in patients with rheumatic heart disease where it's endemic. And then after spending some time in Europe, when I moved to the US, valves have always fascinated me. So being involved with Craig Sable in Uganda, which has been about a 15-year collaboration for me, and looking at the burden of rheumatic heart disease, it was just a natural transition to include that. And so when Craig built a registry in Uganda where there are thousands and thousands of patients who need help, and he one evening came to me and said, we got to do something about it. And so it was not a brainer. It was no brainer. So I'm going to skip this because most of you know what rheumatic heart disease is. But I think it's important to know what it actually does.
In Uganda, in the developing world, the #1 heart problem is rheumatic heart disease. And kids who get it, they suffer from symptoms like not being able to breathe, not being able to play as hard as all their friends, not keep up. You look at their eyes, and you can just see the despair that these children have. I know that if you don't fix their heart, they're going to die.
The Lord is my shepherd. Even though I walk through the valley of the shadow of death, I will fear no evil. We call upon your protection, upon Julia. And Father, we pray, let there be a perfect operation in their life. Let them have the best.
It just breaks your heart to see them struggle through something that's completely preventable. Like it didn't need to happen. They don't need to be this sick.
It's devastating when you go around the country, when you go to our outpatient clinic, and you see children who should be at school admitted week in, week out.
Rheumatic heart disease takes kids down in the prime of life. So they get this disease early when they're little, 5, 6, 7, 8 years old for the first time. When it really affects them is in the peak of their productive years, so late teen to early adults, right when they can be the most productive engaged community members, they get signs of severe heart failure, disability, and they can die in their early 20s.
rest of the states. When I come back home, I will be free.
The real way to prevent rheumatic heart disease is to find patients that are affected in very early stages, give them monthly penicillin for pennies a day, and we can prevent them from becoming one of the 300,000 people a year that die from rheumatic heart disease. Today, we've screened over 120,000 Ugandan children, and between 2 to 3% actually have rheumatic heart disease. So right there, we're talking about 3,000 children that would progress to having severe heart damage. So we can give them one shot of penicillin a month at a cost of under $1 a year and prevent them from needing heart surgery when they're older. Extend that to the whole country, we're talking about tens of thousands of children. And we extend that globally, we're talking about potentially saving millions of lives with this program.
Again, in the interest of time, I'm going to skip this, but we know that rheumatic heart disease is devastating. It's endemic in some parts of the world still. If you see the Western world, simple interventions led to a dramatic decline or even elimination of the disease. But unfortunately, there are parts of the world where it's still rampant. What is striking, and what this slide shows here, is how rheumatic heart disease affects the quality of life and the length of life, as it's measured by the index called DALY, daily, and the average funding that is kind of spent or available for comparable diseases. And the dark red at the bottom is once you have severe rheumatic heart disease, you really don't live very long, and you don't live a very productive life. Yet, the funding for RHD is one of the lowest compared to pretty much every infectious disease. Our team, which is myself, Craig, and a whole bunch of people, we go back to Children's National in Washington, D.C., and you've heard this many times. And this is the philosophy that pretty much all of us start with, but I really think that it's time to start questioning this philosophy. This philosophy leads us to develop tertiary care centers. That's been driven by the disparity in the availability of services to treat patients, particularly heart surgery patients who need heart surgery, both surgical as well as in the cath lab. And this is what we have done in Uganda so far. But very quickly, through our over 20 years of collaboration, we realized that this is not enough. The primary goal of most missions, and when I got involved in 2012 with this program, was to go for 2 weeks and just crank out cases. And the most you could do was 15 cases a week. If you really pushed it, more likely 10 cases a week. So you did 20 cases in a year. But the 2 weeks that you were there were all that happened. The remaining 50 weeks of the year, not much happened. And so we fixed our focus and our goal. And so now when I go to Uganda, I'm more worried about the 51 weeks of the year that I'm not there, rather than that 1 week. And that 1 week is spent preparing the team to do things on their own for the remaining 51 weeks. And this then also spread into the overall philosophy of, any infectious disease management, and then things kind of span out of our experience in Uganda is that, I'm involved with the little red triangle at the bottom, but the base of the triangle is much wider. And if we really want to make an impact, I mean, we really need to start working our way from the base to the apex. So simple things like using penicillin for prophylaxis.
Uganda is one of the most beautiful countries in the world. We are right on the equator. Such a fantastic environment, which I would say is wasted because communities still live in very poor environments. Our rural communities still have houses that are small, squeezed, poorly ventilated, and this is just prime environment for transmission of respiratory tract infections, and therefore we have a big problem with rheumatic heart disease. Rheumatic heart disease earned its reputation of being the world's forgotten disease because, for the most part, it's been eradicated in the United States.
If you prevent strep throat, you prevent rheumatic heart disease. It's a disease that we know a lot about. We figured out how to get rid of it in the United States and other areas. We can do the same thing in the developing world.
Uganda had led the world in the late 1990s in fighting HIV.
Uganda has been hailed as one of Africa's success stories in the fight against HIV/AIDS.
So I saw a blueprint for maybe we could do the same thing with rheumatic heart disease.
Within several levels of research, the one we started with was just to get everybody in the rheumatic heart disease registry. What that means is that if someone is diagnosed with rheumatic heart disease anywhere in the country, we ask that they're sent to Uganda.
But what we need to do is find these kids. How many kids in Uganda have this disease?
It's only right now that we've started to pull together the true numbers and we start to try and fix that in terms that people understand. We've detected that nearly 3% of the children in Uganda have early rheumatic heart disease. Deaths from rheumatic heart disease are all completely preventable.
It's preventable. It is preventable. We can do something about this right now.
It can be prevented. And therefore, we need to intensify our efforts on prevention and health promotion.
And so, just like in the previous slide, there are multiple opportunities for intervening on this disease, and there is a lot of work that is going on within our group as well as globally. Most of those, the dream being that we can have a vaccine to prevent rheumatic heart disease someday, but there is still a lot of very basic interventions which are not going to cost a lot and will prevent the need to spend thousands and thousands on heart surgery and other interventions. We can come back to any of these if you guys are interested, but other than just giving kids penicillin, I think the hardest part is to know who to give it to. And not having trained personnel to detect rheumatic heart disease. Our group has been involved with developing easy tools. And so making heart imaging accessible by using really miniaturized portable echo machines, not the giant machines that cost $50,000, but an iPad-like echo machine that you can just put in your bag and go anywhere. And then adding that with AI and machine learning so that the individual performing those echoes can get real-time guidance as to how to get the most appropriate images of the heart. So if someone puts a probe on the chest, the AI actually tells them, hey, move the probe to the left or the right or tilt it this way so that you get the picture that you need. And while historically those pictures were read by trained echocardiographers, now our team is developing an AI model that would actually flag images and their accuracy has been actually pretty remarkable. So if you look at this here, the machine can tell you, at least for the basic diseases, lesions of RHD, with a fair accuracy, as much as a trained echocardiographer would do, which makes spreading this technology and accessibility tremendously. And if you can screen people and you have access to preventing the disease, I think that's where the biggest impact is going to be. This was, again, has been very popular, and we're trying to work with the global group, which again has a lot of connections with DC, which is also my connection, is to have that go all the way across all areas of the world where RHD is endemic. This is the data that we have from the Uganda program, where if you miss the boat and you do get rheumatic heart disease, the blue is the patients who were treated, while the red is the patients who weren't treated. And this goes to like 10 years, and half of the patients who do not get care do not survive. On the other hand, pretty much close to 100% of patients who do get care do well. And this is, again, a short follow-up of 10 years, but I think that shows the impact that timely diagnosis and intervention can have on this. This is our kind of network, which involves multiple places around the globe. That brings us to our new philosophy. I think it's time to consider this outdated. There are plenty of fish. The burden of disease is immense. And teaching how to fish, my colleagues in Uganda know what they're doing. They can actually do operations sometimes better than how I would do them. They know how to take care of their patients. What is missing is the fishing rod. You could have fish and you could know how to fish, but if you do not have a fishing rod, you'll still go hungry. And that's, I think, is the most important thing, or the challenge that we have. And what do I mean by fishing rod? The logistics, the infrastructure. It's surprising when I speak to my colleagues in Uganda that despite having 1,000 patients waiting for surgery, the reasons why they cancel their surgeries is sometimes funny, sometimes comical, but always sad. Sometimes they don't have gauze pieces, gloves, sutures, valves. And it's gonna take a really concerted and collaborative effort to fix that. We could keep going and doing 2 weeks of mission trips. And the way I see it is that we are then going and providing the service. We could all change our philosophy and say, we're not gonna provide the service. We're gonna build the service for you and help you run the service, which is what we've been doing. In the 15 years that I've been to Uganda, we don't try to do 20 cases every time. We pick 5 of the most appropriate cases. We spend time on teaching and making sure that they understand how to deal with it. And then every year we notch up the complexity a little bit with the understanding that, well, once we have gone through something, we expect you to take care of this on your own. But the logistics is, the infrastructure is oftentimes actually almost like asking to fix all the sets of problems for the countries, and I think that's beyond our scope. However, I'm gonna tell you a little story here. 2 years ago, we went to Uganda. We usually go there on We fly out on Friday, Saturday we do a check, and Sunday we have a team meeting and we start operating, and we spend the week focusing on the job. Somebody plugged the heat exchanger that you need for doing open heart surgeries into the wrong plug point, and there was no surge protector. So both the heat exchangers blew out. So we land there, and well, we don't have heat exchangers, so we can't do open heart surgery. Can't do it safely. And so, well, what are we gonna do? We called Rwanda, which is our neighbor. We called Nairobi, which is our other neighbor. And within eight hours, we had 2 heat exchangers. We sent ambulances right to the edge of the border. They essentially brought the heat exchangers to their border. There was an exchange, and within a day, we had 2 heat exchangers. And so that is, I think, that kind of tells me that there are 3 programs having weekly visits from 3 different mission leaders that are doing 2 weeks of work and not doing much within the other 50 weeks. And if they join forces and try to regionalize, it's going to change a lot. That would be not so difficult as we learned in the previous session, where we all have the same goal. So why not join forces? It's not a competition, it's collaboration. It's going to simplify a lot. And you know, I've heard Owens speak about the logistics and everything. When I go and say, I want to buy 20 valves for this mission, no one's interested in shipping them to Uganda. But if I go and say, you know, we have 3 programs that want to buy 300 valves every year from you, I'm pretty sure we're going to have an Amazon Prime delivery service within a week setup. What I wanted to back this up is with data here. So what you're seeing here, the bars tell you how many cases were done in Uganda by the visiting teams, and the red graph at the top tells you how many cases were done by the local team independently. And so right around 2012, 2013, when I got involved, we said, we're not gonna do any cases. I have actually personally done only 2 cases in 15 years in Uganda. Every case that is done at UHI is done by the local team. I'm just standing around making sure that they know how to do it. And since we backed off, and this data is a little kind of, it got thrown off because of the pandemic, but as you can see, post-pandemic, they've been on the rise. They're now doing 250 cases a year independently. So that's 10 times more than what we could do by cranking up those cases in 2 weeks and not preparing them to be independent. Gift of Life has been our partner throughout and has contributed immensely. Everything that we've done, from research, advocacy, taking care of patients at a tertiary level, and most importantly, in the primary prevention. As you heard Rob say, Gift of Life is funding penicillin to the kids that we screen to prevent them needing future cardiac operations. There's a big Ugandan team behind us, and obviously there's the whole global team behind us that we work with. And like I said, I almost feel like an imposter because everything that I showed you is Craig and Andrea's work. I'm just the tool that holds the knife. And like I said, everybody needs a guardian angel, and we really appreciate Gift of Life's support for this program. And it's really great to hear all of the other initiatives that are similarly aligned. And I really think it's time to join forces. So thank you, and I'll be happy to take any questions.
Pranava, thank you. He made a great effort to be here today, and the work we're doing in Uganda, I really almost feel, even though it's been 10 years, I feel we're only beginning there. And there's so much to do. And I do love that quote there of, did anybody ever think to give them a rod? And that's what we do. I mean, that's what we've done all over the world. And this is an exciting thing. I think in 5 or 10 years, you're going to hear that the work we do in rheumatic heart disease may be more than what we're doing in congenital right now. And to remind you, we do over 5,200 children a year. We provide care to over 5,200 children a year, and the need is great. The need is just as significant for rheumatic heart disease. So thank you for being with us. We really appreciate that. Do we have at least one question out there for Pranava before we're going to start the other session rather quickly so we stay on time? Is there anybody out there has a burning question? One? I'm sorry, I can't see. Ahmed.
I just was wondering, because when our child was growing up, was getting a lot of ear infection, and they said that there's a relationship between that and rheumatic heart condition as they grow up. Can you just enlighten me on this in a minute or two?
Is your question how ear infection causes RHD?
Does it actually affect the child as he grows up to become a...
So strep is a bacterial infection, and when you actually look at the genomes of that bacteria, some of that footprint is very similar to what you have in your heart valves, heart tissue. And so when you get a strep infection, the natural thing is that your immune system is going to try to fight that. And because strep has that footprint, the immune system then starts attacking the heart as well. And that's the basis for why you get repeated strep infections and why that leads to rheumatic heart disease, because our immune system is pretty smart. Every time it gets a signal, the next time it sees that signal, it actually comes up with a stronger response. And so the first infection may not give you RHD, but if you get repeated strep infection, the response gets stronger and stronger, and then it starts damaging the heart. So that's the basis, and that's why we think that if you could develop a vaccine vaccines are basically reprogramming our immune system, and if you can develop a vaccine to teach the immune system that, hey, that is not the protein you need to attack, we could prevent a rheumatic heart disease with a vaccine. We're not nowhere close to it yet, but that would be the moonshot.
That was an excellent question to give Dr. Sinha the chance to discuss that. And I don't want to put words in your mouth, but this is a preventable disease that throughout the world, because of lack of education for parents, they're not addressing their children and the illness that they have early on. Because if that happened early on, we would have less incidence of rheumatic.
Yeah. And the kids that we see in Uganda and the rest of sub-Saharan Africa, they present very early. I mean, there are kids that are like 6, 7 years old, who have permanent heart valve damage as early as that.
Well, I'd like to thank you for being. I'm sorry.
Question.
Yes, Rob. Okay.
Would prophylactic antibiotics be sufficient instead of vaccine antibiotics?
There is plenty of data, and some of it is from our group, that yes, if you treat it appropriately, you can prevent majority of these heart lesions.
Okay. Thank you. So I want to thank you for being with us. You made a great effort to be here, so thank you.
Thank you, everyone.
And I think we're going to be in Uganda with you in November. Is this correct?
Yeah,
okay.
yeah.
Thank you so
Looking
much.
forward to it.
Appreciate it. Thank you. This next panel, Fredlee, you were there somewhere? There you are. This next panel, as we're flowing through this continuum of how we put together our programs and we fulfill our mission, we go from our partners overseas, around the world, to our like-minded partners, and now we have those that are healthcare partners that make everything possible. You may remember last night as I brought up during We Are the World, all of the healthcare partners that were in the audience. It's how we do what we do, but we pick the best at what they do to be part of it. And so today, these are not only partners, these are friends. These are people who probably some of my best friends in the world. So let's see how, who the first person is going to be. Oh, we know who the first person is up here. So this guy, I first met him in El Salvador. How many years ago was it, Gabe? 12?
14.
Yeah, long time ago. And he is one of the best at what he does. He's at the University of Michigan, C.S. Mott Hospital, Children's Hospital. He's a pediatric cardiologist and an intensivist. He has been on multiple missions with us over these years, all over the world, Kosovo, Romania, Honduras, El Salvador many, many times, Bolivia. And so Gabe Owens is not only a great pediatric cardiologist and intensivist, he really is a great guy who cares and really loves the children that we care for, and we're blessed to have him with us. So, Gabe, you're up.
Thank you so much, Rob. And thank you for having us.
Look at that, you got applause right at the beginning.
And that's
My
it.
God.
Thank you so much. Well, we three of us up here on the stage know that we're just in the way of all of you hearing from Fredlee. So we are going to be very, very quick and get to humanism as fast as we can. But, Rob asked me to speak, and I was just so grateful for the offer. And, his instructions were to talk about yourself. That's sort of boring. And really how, GOLI and Gift of Life has impacted me, which is, we'll hear a little bit about that. The word volunteer has come up, and yesterday we all went on stage as healthcare volunteers, but surprise, Rob, you pay me. GOLI pays me. And I get paid in ways that are really not measurable. I'm getting paid by the opportunity and the privilege of doing this work, meeting the patients, meeting the families, and just as importantly, meeting amazing colleagues and collaborators. And that's payment that the University of Michigan doesn't give me. And that's the true thank you. Thank you, Rob.
Thank you.
And thank all of you who support all this work. It's really, really impactful. So maybe I just answered the question there, how's it impacted me? But I guess we'll have to go into some more slides and do a little bit more talk, and we'll share a little bit about my journey with Gift of Life. So who am I? Rob told me to say who I am. He just told you I'm a cardiologist, I'm a cardiac intensivist, work at U of M. We're one of the top surgical volume heart centers in the country. We do a lot of complex surgical cases. That's not me boasting about Michigan. Go Blue. But it is impactful about how our program that I've worked at for so many years has really impacted my desire of doing this work that we've been talking about over the last couple days. I've been on over 20 trips, I think, in the countries that Rob just mentioned, with most of my focus being in El Salvador and building that program, which you heard an awesome description of earlier today. And we'll continue sharing some of my participation. Very passionate about innovation on all levels, teaching, and now really passionate about building sustainable heart programs internationally. I'm also an amateur comedian, but Rob would not let me do my set here today. There are some young children here. I see them in the front row. It would not go over well. So, the tug. That tug that all of us in this room have. Like, what is tugging at our hearts that enable us and give us a desire to do this work? I've always had this tug to do more for children that don't have access. We're hearing a lot about access to care that the children that I see at the University of Michigan do, right? We have this big referral program. We have, parents can get on Google and type in, where's the best place to have surgery for my kid who has this specific heart disease? And if they've got the right insurance, they got a ton of money, they're going to Michigan, they're going to Boston, they're going to Texas, they're going to big heart programs because they have that privilege, right? But what about, even in our country, not everybody has that privilege. They don't get the same access to healthcare. But what about countries where those patients in those places don't have the resources to even think about it? And that's really that tug. What can we do more? What can I do more? How can I use my experience and the things that I've done through the years to make a bigger footprint, a bigger impact? we know, and we've seen this is right from the website, that majority of kids born in countries that don't have resources don't get the care they need. 90+% kids can't get the care they need for heart disease. In heart disease, cardiology, critical care, that's my passion. And can I make a dent in these numbers? That's how Gift of Life has impacted me. So my journey started, what did we say, 2011, 12, something like that, Rob? Lisa Beckman, a wonderful nurse from our cardiac ICU, has since retired. She had come down to El Salvador and had done I think a nursing training, teaching symposium. And she had decided to put a team together from Michigan to go down to El Salvador and start these medical visits, these missions, to help build a program down there so the local team could take care of their kids. She was looking for somebody to, do pre-op care, post-op care, cardiology, ICU. And I was like, heck yeah, I'm in. It's something, that tug was always there, and things just worked out, and she needed somebody, and I joined the team. Now, I wasn't sure what to expect. I'd never done any international work before. I traveled certainly, through, pleasure and vacationing, but never did any study abroad or anything like that. And I'm going to El Salvador. Like, I don't know. What am I going to find there? Burning buses? I mean, that's a true picture. The table over there, they lived through it. But I didn't know. So I did my research and learned about El Salvador through, this wonderful movie. But no, the reality was that they have this beautiful, beautiful hospital there, right? I knew there was desperation. I heard about the need for these services, but the desperation wasn't in a dilapidated, broken down building, right? It wasn't in the desperation of having wonderful care providers, amazing cardiac surgeons that are over there in the back, amazing cardiologists. The people there, they were desperate for resources, for that fishing rod we just heard about, right? They were desperate for that because they knew about their kids. They knew what their kids needed. They just couldn't provide it because of experience, because of training, because of resources, and a true identity of being a cardiac center, and really having that identity and that physical and emotional footprint to do the work. So, like I said, a great team of providers, just amazing doctors who knew what they needed to do, but didn't have that fishing rod to do it at all times. I couldn't even imagine, I think any of us in the room could not imagine knowing what to do for a young, desperate child and family and not being able to do it. Mauricio, a wonderful cardiologist down there, I could not do his job and say, I know what you have, I know what your son needs or your daughter needs, but sorry, we can't do it. And that really hits hard. That really hits hard. When we started going down there in the early years, they had a wait list of hundreds of patients they knew needed surgery but couldn't get the surgeries done. Sure, we'd go down there and do a few and take some patients off the list, but there were so many patients waiting. There were many times in those early years where I'd be doing the screenings and we'd have a list of 30, 40 patients, but some of those patients, even though the list went out a month before, couldn't make it to screening days because they unfortunately had passed. And that was the true reality. Those patients that couldn't be treated, they couldn't be treated at the right time. We didn't have the resources to do it. We had to compete with a general ICU with a bunch of tuberculosis or dengue or burn victims and other things. Those kids needed care too, but really hard to have a big functional cardiac center, without having a dedicated footprint. And some of the development of those cardiac ICUs that we've heard about has been such an amazing advancement for the building the sustainable programs. So that was really the desperation, right? That's what we needed to fix. We needed to get the resources, the footprint, the physical place to do the work so that we could tackle this really, really big problem. To the rescue, Gift of Life, Latidos de Esperanza, Yvonne, and everybody that you've heard about today, that's where we got to work. And I've had the honor and the privilege to be part of this, a small part of it, but it's been really, really impactful for my career and for my life. Teach, train, empower, that's what we did. That's what, Rob preaches and Gift of Life preaches. And where's Benjamin Bloom now? From the work of the group back there and all of their colleagues and the visits from Gift of Life, they're doing 150, 200 cases a year. Kids are being done at the right time, having great outcomes. They have a dedicated cardiac ICU that we heard about, with dedicated providers that are skilled and have the experience to do this work, a cath lab. And I would say it's one of the paramount cardiac centers in Central America. It's super, super impressive. Kids come from all over the region to Benjamin Bloom for the great care that they're providing there. And just to be a part of this development is so special. And not only just doing the work, doing high quality work, the highest level of performance, which is really, really impressive. So that makes me proud. I couldn't take a picture of myself looking proud, but that dude looks proud. That makes me real proud. And even more proud, you heard about today that sort of circle of life, right? To see the Salvadoran team build up over the years and now be the team to visit a beginning program in Honduras. I got a little teary-eyed when Yvonne was talking about it. I saw Rob get a little teary-eyed on stage too, talking about it. And now I'm doing it, and I need some humanism, please. Fredlee. And I was, honored to be invited on that inaugural visit of the Salvadoran team to Honduras, or I invited myself. I don't know which way. I can't remember discreetly, but it was so amazing to see that sort of circle paying it forward, and it really, really special things. Some other programs you heard about, the program Bolivia, La Paz, a dedicated IC was built by many of you in this room support. And now doing 100, 150 cases a year, just tremendous. And then the start of the work we're doing in Honduras has been so impactful to me as well. Hoping to get at least 100 plus cases done soon with the help of multiple missions through the years. Now a few patient stories, if we have time. I don't know how long we've talked so far. So on the screen's left there is Lucas. Lucas is from El Salvador. We heard a little bit about the continued missions that Yvonne and Gift of Life continue in El Salvador with a team from Michigan, where we do a little bit higher complexity cases. But Lucas was a really high complexity case, so high that he's been living at like the limit of oxygenation for about 6 years of his life. He super, super low oxygen levels and not a very high quality of life. But we took a risk. And we did a procedure for Lucas. Technically, things went well, but his body was not so excited about what we had in store for him. And he was a very, very sick young man. We weren't sure he was going to get off the operating table, to be honest with you. But this just sort of speaks to where that program at Bloom and El Salvador has come, that with collaboration with the visiting team and the local team and working together through a weekend, because he was done, of course, on a Friday of our mission trip, right? It always seems to happen that on those Friday cases, something happens. We rallied together, and by the next Tuesday, Lucas was off the ventilator, and now he's home. I think he was at one of the tables. If you were sitting at Lucas's table, you had a special table last night, special to my heart. And we got Lucas through it, but only because of the growth, the development, and the empowerment that was created and the identity that was created at Benjamin Bloom. In the middle is Emily. You heard about that from Dr. Perez today. Emily was a patient done outside of any missions in La Paz. Dr. Perez did it. She came in extremis and significant heart failure from her defect. And as Erica described, she was a sick, sick young lady. Very sick, so sick that there was some thoughts of surrender, of giving up. And this speaks to the continued collaboration and the partnership that we have formed through these years, where I was able to discuss things with Erica and the team, and since I had familiarity with the ICU team there, we were able to collaborate, partner, and come up with some game plans to see if we can get Emily through it, and as you heard today, Emily went home. On the far right there, we have Natalie. Natalie was a recent patient that we did in Honduras, in San Pedro Sula. She had a great surgery, except she had a complication, a surgical complication. Things happen, but what was amazing is how quickly we were able to identify it, how quickly we were able to, with the local team's help and the local team's commitment and involvement, get her back to the operating room. Guess what day she was done? Friday. You guys all know it. Friday. And this is Rodrigo Soto, Dr. Soto. I mean, I don't know, where is he? Raise your hand. Amazing stuff over there. Oh, he's right there on the stage. There you are. He's so humble. He doesn't even want to be found. But he rushed to this girl's, to save her. And on a Friday night, we were all there until the wee hours of the morning. And She was also on the table last night as talking about how excited she is to go back to school, and we got her through it. And again, just the beginnings of a wonderful, wonderful program. And then one more story, Rob Earmuffs. This is a patient that that unfortunately didn't make it at one of our trips in El Salvador. And we work in a very complicated business here. Cardiac surgery is no joke. Cardiology is no joke. And sometimes things don't go the way you want. But there's a little baby that was born sort of at the right time, the right place for our team to be visiting a couple years ago. And we did a high-risk surgery. This patient she would have succumbed if she had nothing tried, just with the nature of her heart disease. We knew she wasn't gonna live. But we decided to take a risk. Even though we didn't have all the appropriate resources or surgical equipment, we gave it a shot. And the little man didn't make it. And it was, it's still emotional to me, even though I've done this for many years, when a patient doesn't have the outcome that we want. And I was physically, emotionally affected by it. But then the family was there, right there in that dedicated cardiac ICU. The family, very young parents, had just lost their little baby boy. And they came to me and they said, "Doctor, thank you. Just thank you for trying." And this next statement just hits me all the time. They said, "Thanks for trying, and we know this is gonna help another little boy in the future," right? Us being there, the experience, working with the team, they were just so thrilled that we gave their son a chance, and so thrilled that all this work is gonna make a difference down the road. And even though they had a loss, they had so much gratitude and gratefulness. I mean, you can't buy that. You can't buy that. So, the impact, hopefully it's come through with my words. It's made me a better teacher, a better physician, and really a better person. So Rob, you complete me, man. You had me at hello, or you had me at pupusa, or you had me at salteña, or probably my favorite now, sorry, El Salvador, you had me at baleada. Muchas gracias. You might understand that, Rob.
So Gabe appears every night at 8 o'clock at the ICU in CS Mod. Fantastic. Gabe has become one of the most sought-after speakers for us, and you can see why. I've already signed you up for February 7th in Florida. Lou Riccio has left, but you're going to speak there.
Excellent, perfect.
You'll be there with me on February 7th. And before I introduce our next speaker, we've mentioned a couple times the ICUs in El Salvador and Bolivia. Those ICUs would never have happened if not for the people in this audience today. I could speak to El Salvador and Bolivia. The leader was our Gift of Life in 7505. You guys still here? Yeah. Those guys, right? Stand up, come on. Right there. So Arlene Schwartz and Bill Donnelly traveled to El Salvador. They explored the hospital, they validated the issues, and they went back home and advocated for a significant donation to that unit, which now is the unit that is making that program possible, with the help of other Gift of Lives that are in the audience as well. But they were the major lead there, as well as Bolivia. Again, they stepped up and were the major lead in Bolivia. And that organization should be so proud of what you do. You've been around many, many years, but your impact is growing every year. So thank you. Rodrigo left. What happened to him? Did we say something? So, the next guy who's up, I see the pictures up there already. John has been doing training visits longer than I've been with Gift of Life. He started probably the early 2000s, John, is that accurate? And it's not easy, as I mentioned last night, for a healthcare professional. They have to take vacation time to do it. Since I've been around, John's probably been on 35 visits with us. And he regularly will not only be on the visit, but he'll put the team together that is going to be there. And he puts together wonderful teams, amazing teams. This is a really good friend, but really an amazing humanitarian, an expert pediatric cardiac intensive care nurse. His training around the world has made a difference in Bolivia and Kosovo and Romania and El Salvador and Dominican Republic and Honduras. He's been all those places many, many times. My friend John Albers.
Thank you. I know you've all got full bellies now, and you really want this to be short, so my goal is to make this the shortest presentation to keep you awake. So in this picture, what you see is my first mission. This is back in 2003. We went to the Dominican Republic, and you see the whole post-op crew here. The actual intensivist is taking the picture. So we did 10 patients that week. It was extremely exhausting. We worked 20 hours a day. Our intensivist took over for the 4 hours that he allowed us to go back to the hotel, take a shower, get something to eat, and then come back again. We worked in shifts, and you could see where we would take naps there in the bed every once in a while, but it was exhausting. So at the end of the week, after working, hundreds of hours between all of us, we decided that we probably should take more people on the mission with us. The team needed to be bigger. But we also realized that, wow, look what we had done. We had, saved 10 children's lives. So, how did I get here? So, I'm a construction worker with an engineering degree, and you're like, how did you end up in a mission? So, probably every person in this room right now is a parent. And you all know the love you feel for your child, and you would do anything for them. So what would happen to you if your child, when you were told that they had a horrible disease that was probably life-threatening? That's what happened to me. We traveled the country looking for the best medical care we could find. We went up in Los Angeles getting our child cared for, and I watched the nurses and the doctors, and I decided that this is something I needed to do. So when we got back, I decided to go back to school nights and became a nurse. Hence, we moved forward. Now, this picture's gotten a lot of airtime. This guy is from Romania. He was a firefighter, and he was on one of our earlier training visits to Romania. And when we came into the room, this is what we saw, a man praying. He had a little Down's child with, I think it was a VSD at the time, and he waited and waited. So on our first visit, she kept on having fevers. So unfortunately, she was not able to be taken care of on that visit. The most devastating news for him was to hear that his child was not going to be taken care of. So the Romanian visits at that time were probably going every 4 months at a time. So the next time the team came back, this is what we saw. The same man waiting at the elevator, praying that we would come and fix his child. Of course, she didn't want to cooperate, and she also had a fever this next visit. We were with an Italian team at that time, Dr. Santoro, and probably by Wednesday, we all decided that we couldn't let her go again. So we decided to operate, and she did fantastic, despite the fever. And this is why we continue to do this, because we cannot stop. Oop, we lost one. So the reason why we go on these visits is not for recognition, but for the patient. And I work with some of the finest nurses in the world, whether it's in Honduras or Bolivia or Romania. And I am partial to Albany Med because that's where I came from. And these are some of the finest nurses, like I said. This is a child from Romania whose mother thought that she really would be healed and her face would be better after heart surgery. This is another child in Bolivia, and I believe we've gone there 12 times now. Some of the nurses here were gasping for air, literally, every visit. This is a little Dominican child with one of our volunteer nurses who unfortunately is not with us anymore. She succumbed to an illness, but she will always be with us. So now this is probably the most unusual picture you will ever see. So missions change people. So this, believe it or not, is our cardiac surgeon in the Dominican holding his post-op patient. I guarantee you will not see this almost anywhere. So why does it change you? I would probably say that I've done over, well, I'm close to 43 missions now, and every time I would come back, and about after 2 months of working, my coworkers would say, it's almost time for John to go on another mission. You learn in perspective what's real. You know, why do I go on these missions? There's no politics, generally. There's no, computers. There's no people to worry about, lawyers. We're here just for the children. This is why we do this. It changes you. Now, this surgeon would definitely not hold a child at Albany Med. Now, if you notice in this picture, this is not a staged photo. This is the nurse just purely looking into the eyes of that patient and loving it. Every day, we got to take these kids on a walk, and this is what we're there for, to make that child better. So if you look into these eyes of this Bolivian child, could you ever say, no, we're not going to help them? So in this picture, it's a little different. We don't show any patients. What we're showing here is, yes, Michaela is looking back saying, hey, John, but this is training. So in Bolivia, in the new ICU, what we've done is we set up training days, and this is instructional, right? So we have an attending there that's teaching the residents, the nurses, about what we can do to improve their lifestyle there. How can we better improve how they're taking care of those patients? This is actually Dr. Bakar in the old ICU in Bolivia, teaching them about pacers. Now, if everybody here, there's nothing better than this Kosovoan child saying, after my surgery, how did I do? Give me a thumbs up. Thank you so much.
You know, when I asked John to speak, I had never heard John speak before. Well, not in presentation form. And I know his story, but I also know his heart. And there's nobody out there that works with us who gives any more than John does. John will stay at a hospital 24 hours if a kid's in duress. I've seen him stay on a Saturday that we leave at 11 o'clock, 12 o'clock at night. He's there until 8 or 9 o'clock. That was fantastic, and I think you did yourself a disservice now because you are going to be on the list of speakers that we're going to send around because that was fantastic. Let's give John another round of applause. So next up is a guy that I met, excuse my back, Fredlee, is a guy I met in December 2008. I remember it very, very well, and we was on the beach in Boca Chica, Dominican Republic. Yeah, a lot of beaches. We had a conference, though. Robbie will remember the conference. It was a conference we had with about 100 healthcare professionals, and at that time, Rodrigo was just one of many. But over the years, I've gotten to know that he's not one of many. He's one in a million. And we are very fortunate. About 6 years ago, I sat down with Rodrigo and discussed him joining Gift of Life International. It was always a dream of ours to have a clinical consultant that was a pediatric cardiac surgeon. That was one of the best in the world. During his tenure with Gift of Life in the last 6 years, there was a year that he did over 200 surgeries internationally. That's amazing. It's amazing. And not only, please applaud him. Not only is Rodrigo a great surgeon, he's a great teacher. And the work that he's done in Bolivia with Dr. Perez has been significant in developing that program. The work he's now going to begin doing, and we've already begun doing it in Honduras. I will guarantee you Honduras in 5 years will be doing 100 kids, and Rodrigo will be right in the middle of it. So I'm very proud to, again, introduce my friend, Rodrigo Soto.
Thank you. I'm gonna, first of all, I'm gonna explain you a little bit who I am. And excuse me. And the road that took me from my birthplace to be sitting here this afternoon in front of you, I'm going to tell you what I do, how I do it, but the most important part, I think, is why we do it. So I was born in Chile. It's a skinny, long country in South America. And that's where I did my med school and my general surgery training. And during general surgery, there was, to be honest, there was nothing that I really was exciting to me till my last year when I walked into the cardiac ward. And I saw a surgeon clamping the aorta, stopping the heart, open it, fixing it, closing it, and the heart started beating again. So it was like mind-blowing to me. And I thought that was the coolest thing ever. And at that point, I said, one day I need to do this. And different things happened in between. But after finishing general surgery and ended taking an airplane bigger than that to Australia, to Melbourne at the Royal Children's Hospital, where I got my training as a civil surgeon. And it's where also I met, my boss, and that then became my mentor. And so from the cardiac perspective, I'm very much Australian-made. When I was there, on my last year, I asked my boss, so you will be in my shoes, what will you do now? And he said, well, I will go to a place and they do things very different than we do. So what better place than France, right? Frenchies do everything opposite to Anglo-Saxons just because. It was a great suggestion, and I'm so glad that it did, because when I was in France, I learned that definitely there's 1,000 ways to skin a cat. And I learned that, I could have really good results doing something slightly different or completely different that I have learned just a few years ago. And that lesson of humility, I think that definitely helped me to perform the job that I do today in global health much better. After my fellowship in France, I came back to as an attending to the Children's Melbourne in Australia, where I was, working for quite a few years. And while I was in Melbourne, I got out of the blue, I got a phone call from my mentor. I said, listen, Mike, I'm going to Central America, to Managua, with an organization to do surgeries. Would you like to come with me? I said, yeah, why not? So I went to Managua, and I spent 2 weeks there with a team at that time from UCSF. And it was amazing. That experience, as just many other speakers have said, and Gabe just said, it changed you and changed me completely. And that completely took a detour in my life. And it's one of the reasons that I'm here talking to you guys today. And being there, things were definitely very different that I was used to in Melbourne. But you know what? We have what we needed. We have what to do safely, what we needed to do. And we were doing, small kids, and we were doing some very, very sick kids. Usually in ICU, you measure how sick the kid is based on counting the infusion pumps. Usually over 4 or 5 is bad, right? It's very sick. This kid has 7 infusion pumps and is connected to a ventilator. That's his daddy and so on. So we took care of the patient, and there you are, 1 infusion pump, extubated, and doing great. And that's those 2 weeks. They were talking about 2001, very old, and was like completely, yes. I understood why, and there were all the training from school to med school to general surgery to CV surgery, that started making completely sense in my mind. After that experience for many years, going to Managua for 4 or 5 years, I came back to Santiago, Chile, my birthplace. And I was hired to set up a pediatric cardiac unit and an ECMO program. Very different because I have, a couple of $1 million budget, and I could hire the people that I wanted and so on. So it was a different thing. But however, the process in which you build the unit also was a great training for me and prepared me for what I was going to do. At that point, I didn't know, but I was going to do a few years later. After a few years, I finished that project and so on. I had the opportunity to jump into global health as a full-time job. And when that offer was presented to me, everybody around me and my friends at the time in that unit, they thought I was a maniac, that I need an intervention, that you cannot do that, et cetera, et cetera. But I thought that was the coolest offer ever. So I took it. And since 2013, I've been working full-time as a global pediatric cardiac surgeon. And one of my first assignments was an easy one, the Middle East. So I was working in 2013 in Libya, Benghazi, for a year. That was right after the Benghazi affair. And in 2014, 1 year in Iraq, in Nazareth. And apart from the fact that I was exposed to a very different culture, very different religions and so on, which was amazing. Apart from that, I realized, well, the needs that I've seen before in Central America, they're still the same in the Middle East. And when you look at this map, the darker the color is the people that lack access to proper anesthesia or surgery. And as you can see, most of the planets does not have it. So it was like, okay, this is a big, big problem. After spending, those 2 years and doing another things in between, all related to global health, I was lucky enough to meet Rob and Give for Life International. And then after, a short period of time, it was no-brainer to me that Give for Life International was the organization that I wanted to be part of, because certainly we share the philosophy. We understand the concept of building local capacity, and it is a very transparent organization, and that's exactly what I was looking for. So the concept of building local capacity, which is something that still seems to be something new for some people, but is certainly the only way in which we can solve the disparities and the problems in the low and middle income countries. Trying to do visits, in which you just go for 1 week and that you never return in the next year and you just do surgeries, it is great for those 5, 8, 10 cases, 10 patients that you're going to be treating, but you are not leaving anything behind for that particular unit or country. So it's important, and this is something that I learned from Rob. There's 4 things that are fundamental in order to build local capacity anywhere. First, you need a local team to be trained. We need, a counterpart that we're not working with. The hospital administration need to support the program and the idea. We need certainly government support. Minister of Health and the government must be involved in order to give consistency and make this program sustainable in the long term. And you need a local NGO to work with. And there's a lot of those here with us, particularly with me, Latiendo Porti in Dominican Republic, TCCA in Canada, regarding government support. No better example than Guyana, in which the government is completely on top of what we're doing, and so on. But these 4 pillars are fundamental in order to develop local capacity. For our part, we work on training. We work on education, and we keep consistency. We go to the same place 3 or 4 times a year for a week, and working with exactly the same people, the same local team every time in order to build over what we have done on previous trips. So this is something that goes beyond semantic for me. We don't do mission trips. We do training visits. And again, it's not just semantic, it's a philosophy behind what we're doing. We are actually going there to train the local team so we can become obsolete as soon as possible, because you saw that the need is huge. So we're happy to be in a place as much as we can in order to live in a place in which they're independent, and then we can move into another program. The magnitude of the problem is right there. It's 1.2 million children that do not have access to care per year. Of those kids, over 50% of them, they will never celebrate their 5th birthday. One of the parts of my job is not only be leading the team and doing the surgeries, but also building a team. And building a team is not something that is first come, first serve. There is a philosophy that we apply in order how to choose our volunteers and how we build our teams. That's a picture of the local and the visiting team in Guyana, April this year. So what we require from our volunteers and how we build a team, we need an experience of minimum of 2 years of that person working exclusively in a pediatric cardiac unit. We always request references and background. Most of the time, we do have a virtual interview with the applicant to see if, what that person believes is going to be doing is exactly what he's going to be doing, and there's no disappointments. When we build our teams, we have some people that is recurrent, they go always at the same place, like Gabe in Honduras or John going to La Paz. So there's a third of our volunteers that are veterans and they go all the time to the same place. We have another third of volunteers that are veterans and they may go to different places. And we have a third, the other third part is basically the rookies, people that is doing for the first time one of these experiences. And we are very clear in what the expectations are and why they're going to be doing what they're doing. We truly believe that quality matters. Even if you're working in a limited resource setting, you still can deliver the best care that you can without sacrificing quality. The fact that we operate in another country with limited resources doesn't mean that we will be doing something that we should not be doing in the United States or any developed nation. So the same standards are the one that we keep wherever we go. So this is Fernanda and Miranda. Those are my two beautiful daughters. That picture was taken at the moment in San Fran, yes, a few months ago. We were spending our vacations. Those two are the lucky ones, right? They're lucky because they were born without any problems. They're lucky because if anything happened, they have access to care, to go to a hospital or see a doctor and so on. But they're the lucky ones. I truly believe that any child have the right to have a full and productive life. Neglecting that right is telling that child that it doesn't matter. And certainly, if I cannot say that to my daughters, I cannot say that to Luana in La Paz. I cannot tell Nadine from Guyana that his life doesn't matter. I cannot tell Amy for La Paz that her life doesn't matter. Certainly Genesis from DR, I cannot tell her that her life doesn't matter. Athea from the Philippines, Shakira from Guyana, I cannot tell her that her life doesn't matter. And I know that the people that is sitting here believe exactly the same that I do believe. So Gift of Life is doing, the network Gift of Life is doing now over 5,000 children a year, and we want to keep doing this for the next 50 years. Thank you.
Thank you, Rodrigo. And I hope you're all out there beginning to see why we are so successful out there in the work that we do. Those are three of the finest doctors and nurses who are in this world who do this work. And we are very fortunate they're on our team. And as I said last night, we have over 100 of them the criteria that Rodrigo talks about has been put together over years and years of experience. Not everybody is meant to be on a pediatric cardiac team. These three certainly are. The next speaker I met on a beach in Uganda. No, it's not true. Just kidding, just kidding, just kidding. The next speaker is somebody who is an example of when you take what your skills are and you think and you imagine what you can do with them out of your box. And I think Fredlee stepped out of her box and came on a visit. Was it the first time was it Uganda you traveled with Robbie and I? I said Robbie and I, but we traveled together. You remember that airplane trip? It was a fun one. It was a trip, but I remember you on that visit to Uganda, and I remember seeing, your thought process and how you could immerse yourself in what we do, and you've heard already, unsolicited, the impact that Fredlee and her humanized care has made in El Salvador and Bolivia. And I will tell you that in both of those countries, it was so well received, and it's the reason why we're so successful in those countries is Fredlee. And you are the founder and the director, and it says it on the screen, but that's not what Fredlee is. Fredlee is a human being who wants to make a difference in this world. She took her skills and did something that nobody else that I know of has done and made a difference in the lives of children, parents, and healthcare professionals in the country we are. I am very, very pleased, honored, and blessed to introduce my friend Fredlee Kaplan.
Can you hear me? Okay, I can hear me. Thank you. You know, Robbie, and Bill Curry were the first people who introduced me to Gift of Life. I'd like to recognize Bill Curry. I can't see because of the light. Where's Bill? Bill was our international president at the time, and I joined the Rotary Club at that time, and he was in my club, and I asked him to get involved, and he set me up to meet a family at the hospital. And it was after that that I saw a need, because the mother was told and was crying when I went to visit that her child had a 75% chance of dying on the operating table. And I said, who said that? And it turned out not to be her doctor. It turned out to be a resident. We investigated and found out, and that was the beginning of, at least in terms of Rotary involvement, how Rotary needs to stay very close to these families. Now, this was 18 years ago. Much has changed, and Rotary has become much more involved, and successfully so, with the families who come in, because they come alone. Imagine taking your child to a foreign country and you don't know anybody and nobody's talking to you. Well, that's what happened. So I am a certified clinical social worker, a licensed marriage and family therapist, and a school psychologist. So I come with a lot of learning, training, and humility, thank you, yes, about what we can do and when we can do it. So it was around 2012 that I started to travel more with Rob, and we went to Mexico, Uganda, El Salvador, Kosovo, and Bolivia.
You forgot Lebanon.
And Lebanon, oh my God, and Lena's here. Lena, I'm so sorry.
That's why I reminded you, because you'd be in trouble.
Actually, I was able to teach one day in Lebanon, and what a fantastic country that is, too. What this program has given me is the chance to help children in a way that I have never had before, because although I have stepchildren, I've never had a birth child. And this brought me very close to the parents, as well as the children and the staff, and everybody is tugged on, talk about tugging, in so many ways, emotionally, spiritually, and intellectually. So GOLI and Rob gave me the opportunity to develop this program to provide comfort and safety and empowerment to the staff for the care and the comfort of the children and families and staff. What I saw was that everybody is affected in the hospitals. The leadership team in El Salvador started with 3 and is now close to 9. We trained there. I made 11 trips to El Salvador, and these people were so receptive and so welcoming. I think some of it comes from desperation, as you talked about, because there were so many deaths of the children, and the nurses were struggling to keep up with what was needed to help these children before, during, and after surgery. So humanized care involves 3 pieces: authentic connection and presence, and support for the staff, children, for the families and children, and also to build a sense of community among the staff. And why that's important, I'll get to later. Stress reduction techniques and self-care for the staff. We also look at neuroplasticity of the brain because, you know, if somebody's upset and you say to them, calm down, what does that do? Nothing. Makes them more upset, that's right. So how do you do this? You have to bypass the conscious mind and work with the limbic system in the brain in order to activate the soothing response system. I can't go into detail, but if anybody wants information, I'll be happy to share it. Melvin was a 5-year-old at the time, and this was early on, before we actually created the program. The doctors came to me, he was in the step-down unit, and he wouldn't get out of bed because his surgery was over and his mother was coming with his father. His father was there. His mother had not come at all because she was too afraid to see him with tubes and the surgery. So I went over to him and I said to him, I told him who I was, and I said, I understand that you're having a hard time getting out of bed. He goes, see? And so I said, would you like to be able to get out of bed to go home? See? I said, okay, I understand your mother is coming. How about that you show her what a brave man you are, what a brave big boy. You survived the surgery and now you've got to go home. You've got to walk. You've got to go out of the hospital, go home, go back to school, go back to your life. He said, see? So I asked him to sit up, practice sitting up, holding onto the sides once. And he did it, and it was like this. And I congratulated him. Wonderful. I said, now, I had checked with the doctors. He was fine to do this. I don't interfere in medical treatment. I'm not a doctor. He lied down. I said, and he did it again. I said, okay, in 10 minutes, in a half hour, I'm going to come back, and I have to talk to other children and parents, so I want you to do this on your own 5 times. When I came back, he was standing in the room waiting for his mother, but he was standing like this. So we congratulated him, and I said to his father, you have raised a wonderful boy here who has learned to be flexible and can grow. This simple dynamic, I had to take into consideration the fears of the mother, the presence of the father, and the worldview of the child, that the world is a scary place. So I had to give him a reason to not be scared, or at least to balance the fear with confidence. In the past 3 years, we have brought on 2 other people into humanized care. Paula is a psychologist from Mexico and has been to Bolivia with me and recently by herself. Lauren is a child life specialist and went to Bolivia with Paula this time. So we started in El Salvador. I can't remember the starting date. It might have been around 2016 or 15. 2 remarkable things have happened. The government, the Ministry of Health, has now asked them to train other hospitals. I think this was mentioned before, to train other hospitals in the country to set up humanized care teams. The humanized care team in El Salvador has been now made a special, significant program of the hospital. It isn't just a team, it's a program. The Bolivian program, so you can see how we affect parents and children and staff in one hospital, and then we're slowly changing the healthcare and the medical care in the country. It's mind-blowing. In Bolivia, with the leadership of Dr. Perez, who is just wonderful to work with, they started with three's a lucky number, 3, and now they're at 7, who come to bi-weekly meetings with me and with Paula and Lauren every week, and have been doing this for 3 years, and we do it online. Somebody asked about online training. It is successful, it works. The other thing they've done that has been really smashing is they have developed, I think they mentioned this, the telehealth program where they're meeting with families online pre and post surgery. Now this is key because sometimes when families are not prepared for surgery and they're told their child needs surgery, they leave and they don't come back. And this is devastating because the child most likely will die. So we need, this is all for the goal of maintaining contact, maintaining information and compassionate communication while they are not at the hospital. Now they start with this when they, in Bolivia, Dr. Erica does meet with them. There's an intake person, and then Dr. Actor meets with the families and the children, and then the psychologist, Patty, then sees them, or one of the social workers. So they immediately go through a 3-pronged stage where parents are informed and engaged. We want to engage the parents because they know their children. We don't. We know medicine. So by engaging the parents, the child is more relaxed. If the parent is absent or tense or totally scared, the child is going to be frightened as well. So we need to impact the entire family system. In the first case that I told you about, I didn't know that the mother hadn't come. I had just arrived in El Salvador and then found out about this. So what we are doing is alerting staff to know what to look for of signs of stress. And absence is one of the biggest signs of stress or avoidance. So we use psychoeducational informational techniques. We do training in self-care and stress reduction. And we use role-playing, and we ask the trainees to devise the role-playing. Now, as you know, these countries have had war, famine, political conflicts, poverty, and high mortality rates of children. This does not make it easy to work in these countries, but it makes it the most rewarding to know that you can meet some of these challenges. The nurses face life or death every day in the ICU, and at the same time, they have to provide comfort and care. Imagine, if you're upset, what is it like to then take care of your child or somebody else's child? It's very difficult. So when families are protectively angry or aggressive or withdrawn, often staff becomes withdrawn, angry, defensive, and stressed, and sometimes they don't want to come to work. And mostly they feel less effective. So when we work with them, we help them to become more aware of what they're thinking and feeling, whether during a stressful moment or not. How we do this is through the body. The body-mind connection is incredibly powerful. It's not news. It's been around for a long time, but we have not seen this much of it done in a hospital setting where staff are under so much stress. One of the examples that happened in Bolivia is that families were only allowed into the ICU a very, very short time. And more, in El Salvador, it was more the fathers than the mothers, which I never understood, except for the patriarchal kind of thinking about families. So in Bolivia, we learned that the families, in coming in, they were allowed in 24/7. They began to want to take over treatment because Erica told me an example. There were a couple of young children and a baby who were salivating because they couldn't swallow. This was either before, probably after surgery. So the mothers wanted the teams to aspirate the liquid all the time. Well, from what I understand medically, it's dangerous to do it all the time. And they couldn't because there were 7 other children in the ICU. So the parents became aggressive and undermining the nurses. Now, this is a huge stress reaction. This is not about bad nursing or bad parents. This is about misunderstanding and desperation to save their child. So the solution, we're working with the head nurse of the hospital and the head nurse of the ICU, and she's writing up limits and instructions for parents once they come in to the ICU. So they know they're going to be asked to leave during a procedure, but they will be told what the procedure is, and if it's not life-threatening, they will be told that. So they're more likely to leave, but they weren't leaving, which made it impossible to do some of the procedures. This example, to me, is very powerful. We're trying to empower parents and staff, but there are very important roles and distribution of responsibility that has to be maintained. So how do you do that in a kind, gentle way? You do it by information, you do it by kindness and letting the family know that you understand that it's difficult, but this is what we need to do. We're going to ask you to leave, and we'll ask you to come back. And it's working. It's starting to work. What happens with this now is that I'm watching the time. It builds more of a community among the medical staff. They feel more safe with each other. They can talk to each other. Sometimes the feelings of shame or embarrassment or guilt happens to parents as well as nursing staff and physicians. And these feelings can prevent open, authentic communication. Now, I don't want you to think this is psychotherapy, because it's not. It's not touchy-feely. It's really education. And when we ask people, for example, to become more aware of what's going on in their bodies, we'll ask them to just settle in their chair, close their eyes if they feel comfortable, and we'll take them through a process, a very brief process of meditation and breathing and relaxation. And then we teach them to teach it to others and to the parents. So this is emotional regulation. That's what we call it. And one of the most poignant situations in El Salvador was a 6-month-old who had surgery. And I was there the next day, and this child was making no contact with anybody. He was sitting with his eyes all the way up in his head. He was breathing. He wasn't responding to much stimulation, and he wasn't eating very much. And this is a child who had short limbs, so he had other issues. So I went over to him, and I brought the resident and a nurse with me, and I just touched the head, the back head of the, you're too far away to example, but I would touch the back of, here we go. So I asked the resident to do what I was doing, and he goes like this. He was hesitant to allow himself to feel impactful. He didn't know what to do, so I showed him. And I said, you got to let the child know that you're there without overpowering him. And I had to leave because I had to see other families. So I said, could you stay with him until we get a doctor and a nurse to assess the situation? Because not only did he drop his eyes when I touched him, he looked at me and he started to cry. So the dissociative response broke. But if I walked away 2 seconds later, it would go back. So we needed to keep him in reality. I learned later that they finally took him to OT and PT. And I think that we, with the resident and the nurse, saved his life because nobody thought he was going to live. Oh, I haven't done the slides. Okay, so here we are in Bolivia. We've continued this training online, as you can see. The leadership team is about six-fold with Dr. Erica Salet Quieros, who's the chief pediatrician, the head nurse of the hospital, the head nurse of the ICU, and the psychologist. We notice that when we give information, that's Paula in the picture on your right. Oh, there's a slide missing. That's okay, I'll let it go. Oh, there it is. This baby was crying when I was teaching nurses in another room, and one nurse became very activated. So she went out, we went out with her. She took the child's hand and put his own thumb in his own mouth rather than giving him hers. I said, why are you doing that? She said, because he has to learn to do it himself. Which I thought that agency for a young baby and is the same as what we do with parents and staff. So these are the mind-body approaches. We had the second picture, Qigong with a child, which is really raising your hands and lowering them with the breathing sequence. And the Salet did it with the child. I think he was a year and a half. Usually children under 3 can't take direction, but this one did. The picture on your far right is me working with the baby that I touched his head. Here's a mother who was overwhelmed with the sobbing of her child, and we brought in play medical materials. It distracted her, and eventually she calmed down. But before we did it with the child, we talked with the mother first. So the kid is screaming, but I wanted to establish the contact with the mother first to empower her. And we asked her, what do you do at home to help your child stay calm? So we had this whole conversation, and then she connected with her daughter. Role play is a very big method to use for coaching as well as for people being able to experience a different role. We had a resident who said after a role play, oh my God, I never understood what it would be like to be a parent with a sick child, and he was a man playing a mother. We like switching roles. The next, sorry. We do, the cartoon on your left says, remind me what I was talking about, I wasn't listening. How many of us stop listening when we're talking to people? These are pictures with medical play. The ludoteca on the right is one of the play therapists, also the one on the left. Here's another picture of medical play. The child in the middle wasn't cooperating with the respiratory therapist, so I said, well, let's play with balloons. And he pretended to blow it up. They blew some up and they played with balloons. He was sitting up, he was breathing, and they couldn't get him to try the respiratory mechanisms. Palliative care we have just started to bring. There is a palliative care team in Bolivia, but we've started to bring some specific techniques through Paula and Lauren. Before we get to this slide, I want to introduce you to somebody. His name is Raza Patel. Raza, would you come up to the stage? He and his family are very dear to me. Raza raised $1,600 in one day for 2 hours. Raza is a chess champion. He's number 51 in the world. In his age group, he's 11. And Roz is going to tell you why he raised this money and how.
Okay, so should I start speaking now? Okay. Hello, my name is Raza Patel. I'm 11 years old, and I started a nonprofit with the help of my parents called Moves for a Mission. We raise money for children in need through chess events, and we had our first event where we raised money for the Gift of Life International. When I was younger, Auntie Fredlee would come to my house and tell me where she was going and what she would be doing to support the Gift of Life International. And it felt really meaningful for me to be able to support a charity that I had been connected with for so many years. I supported in the first event one specific child named Alexis, and he's a 9-year-old boy, almost the same age as me, who loves soccer just like I do. And I got to talk to him, and after his surgery, thanks to Rob and Fredlee, and I felt so happy to be able to talk to him and hear him share his passion and to be able to support him. So it's a short speech, but I'm very glad I was able to help, and I feel really grateful to be able to stand here and talk. So thank you for hearing me speak, and for.
Raza, are you finished?
Almost, yeah. And for hearing my story. So thank you so much.
Thank you, Raza. Okay, you can go back to the tape.
Stay here.
Okay.
With me. Come here.
Raza is amazing. He's a young boy helping other children in need. He and his family are very generous and have started this charity, which has also contributed to Ronald McDonald and several others. Thank you so much for what you do.
Thank you, Raza.
Okay.
And I'd like to say something.
Wait. Go ahead.
No, you say something. I would never interrupt you.
This goes on all the time. We tease each other, right?
Sorry?
Nothing, never mind.
I just wanted to congratulate you for the work you do and how you show your heart to everybody. And remember, it is never bad to have short speeches, okay? It's a very important thing in life. More people should learn that. Thank you. You're a good guy.
So if a young boy can raise $1,600 by having chess tournaments for other children, and they know what they're contributing to, imagine how much more we can do. For me, this program has changed my life. I've become more courageous emotionally, spiritually. Working with these families and with Rob and all the teams has strengthened me enormously. And I didn't want this program to end with me, so we are training other people. Not only does each country, Bolivia and El Salvador, have a champion for this program in their country, and they are the ones that are making it extend into the future. And my hope is that with the introduction of Lauren and Paula and others, that we can continue to make it grow. So, thank you.
Thank you. Excellent. So, my view, another great panel. We actually have a couple minutes before our break and then our final session. Let's see if we have questions out there of really some great presentations. Albany.
It is on now. Okay. For the third time, I'm Albana Krasnici. I'm on the board of directors of Gift of Life International. And I did meet Rob at a bar, not at Jamaica Beach.
That's right, we did meet at a bar, didn't we?
I don't have a question. But I do want to thank these great panelists here, our team. I've been on missions with them many times, with Harm, Joe, Gabe, John, Fredlee. I hope to go on missions with Dr. Soto and with Dr. Hisham. And I've seen firsthand how much work, how much love, dedication they give out of themselves for these missions. To see Gabe bring it back to life a kid in Kosovo, Nina, it was nothing short of a miracle. John is 24/7 with the kids when he's working in Kosovo and other countries as well. So thank you on behalf of all Kosovar mothers and all the mothers out there that you've helped save their kids. Thank you, and I am truly honored to have been on missions with you, to have gotten to know you. So thank you all.
Anybody else? What? Mark, yes.
Hi, my name's Mark Ford, Gift of Life, Panama. A lot of you guys have come up to me remembering my dad. So I'm second generation Gift of Life. I think I want to add on a little bit what Bill said earlier with what Fredlee was mentioning about humanizing the part of the families that are involved with the child that we're helping. When we help a child, we know it's not only the child, it is the family. The family is going through as much as the child is, if not more, a lot of times. For us, in a lot of our countries, these families are coming down from mountains or from parts of the country that you might have to walk, ride a mule, get to the main road, get a bus to go into town to get to their appointment at 7 or 8 in the morning. So when we help a child, the recovery of that child is the recovery of the family, not just the child. It means that they get to come back to a normal life. That child, this is one of the few kinds of foundations and help that is provided where from night to day, it changes the child's life and the family's life. And the help that you were mentioning about, how to prepare the family for that change or for that reaction of, this is a very scary thing for a family. We have learned that the best way is, one thing we did is we actually are aligned with another foundation who are mothers of families who have a child recovered from a surgery. So they know best the situation that these mothers or these fathers are going through. We try to incorporate families that have directly as well in the before, the during, and the after. So, that humanizing part is a big part of the cure of the child and the family because, as Bill was saying, when the family comes up and the mother is there helping out the child, a little day at the spa does wonders. It brings back saying, hey, you are still human, and it's not only about the child, it's about you too. And so I think this is an important part of our mission, is to understand that it's not only the child, it is the family, and that we have to involve them and humanize the part that you were saying. And I think that's a very important and courageous thing that we are doing on that part.
Thank you, Mark.
Thank you.
Other question out there? Anybody else? Ahmed?
Well, I'd like to compliment and congratulate Reza for his great effort. I'd like to compliment and congratulate Reza for his effort and give him an advice. Chess requires smart people. If you want to raise more money, next time do a backgammon.
Robbie's pointing at something here. Hi. Thank you, Rob. Florence?
I want to take this opportunity to thank the Gift of Life for the work they have done. I have been on mission with them several times since 2008, and they have done an incredible work with children, not only all over the world, but I can speak to my experience in Haiti. They have done an incredible job. And many families, many members here are talking about the difference that the families have experienced when a child has been healed and or the child has had the opportunity to access heart surgery, the difference that it has made, not only with the child, but also with those families. Their life has been changed. So I take this opportunity to thank each members of the Gift of Life and to all the work that the volunteers have done, doctors, nurses, other volunteers. So from the bottom of my heart, thank you.
Thank you, Florence.
I'm Celia Weintraub with the Brooklyn Bridge Rotary Club. I'm curious to know the name of the doctor who did the rheumatic heart presentation from Uganda, and also I want to know how much those mini echocardiogram machines cost.
So that was Dr. Pranava Sinha, and he's from Minnesota. He used to be with National Children's, and he's been working with us in Uganda almost 10 years now. I can give you his contact information if you'd like. And what was the second? I'm sorry. What was the second part of the question about how much does a visit cost? So we actually have a great deal through our board member Harm Velvis, Dr. Velvis, for a pediatric cardiac, well, not for an echocardiogram with a transesophageal probe, which you can put down the throat and get a very good view of the heart, with two smaller probes, is $52,000. We have what? Oh, the handheld ones? I think it's a couple $1,000s. Yeah, and I'll tell you what, it was an amazing. We have some pictures of what we did in Uganda with little huts that we had the children. We would screen 800 children a day with these handheld echoes. It was amazing, and within 5 minutes, they were able to tell if the child had a rheumatic heart disease. It was really great. So yeah, I'm sorry I got that wrong. Okay, we are on schedule. Can we take the break and be back right at 2:30, please? We have a great panel. Please come back for this last panel. It's what makes Gift of Life, Gift of Life. I want to thank these, Rodrigo ran off of here already, but I want to thank these four panelists. Again, as I said, they're my friends, but they are an example of why we're able to serve the children we serve. Thank you, guys. John.